And it's an absolute delight to be here with you this evening, and a real privilege to be hosting Beccy Baird from the King's Fund and Becks Fisher, one of our very own Next Gen GP leaders and also senior policy analyst at the Health Foundation, to start off the new year and the new decade. Well, actually, I say that. I did wonder to myself then the other day whether the new decade technically started last year. So I may be a year late, but hey, we're going to call it the new decade from 2021. To start the year with a look to the future after what's undoubtedly been an incredibly difficult 9 months at the tail end of last year, and continues to be an incredibly hard time. So in some ways, an odd time to look forward, but actually I think really important to give ourselves a bit of space in the midst of this huge pressure we're under, to orientate ourselves and remind ourselves that it's not going to stay like this, and that there is a lot of really positive and exciting stuff on the horizon, and that general practice remains an incredible privilege and a wonderful job to be doing. So I'm hoping that tonight's conversation will have a couple of functions. So firstly, as always, to re-energize ourselves and to remind us of a bit of purpose and direction that transcends the pandemic, but also to be thought-provoking. And I'm sure that both Becks and Beccy will bring a really fascinating insight from jobs that allow them to spend time thinking deeply about the wider implications of policy and operational developments within general practice, and some of the challenges that we face as well from a slightly different perspective to what we see and feel in the consultation room. So I'm really, really excited about this. I'm first of all going to ask Becks and Beccy to introduce themselves individually, because they will do a much better job than I will. And then I've got a couple of questions, as always, just to get things started. But I really would like this to be interactive. So please do put your questions in the chat as and when they occur to you. Or if you've already got questions, wonderful, get them in there now. You can put them in the chat to everyone, or you can send them to me personally. That's absolutely fine. When we come to it, I'll ask you to come off mute and to ask the questions yourself. I think that would be a really nice way to keep it interactive. If you really don't want to do that, you can just put in brackets afterwards, you ask it, or don't come to me. And I'm happy to do that as well. And we'll see how it goes. We've got an hour and a half. We'll definitely be finished by 9, no later. And I think that depending on how we're going, we'll probably aim for a short breakout in the middle, partly to give ourselves a bit of a change of scene and a change of activity, and then we'll come back together. So just to get us started, Beccy, thank you again for joining us. Could you tell everyone a bit about yourself and where you're coming from tonight?
Great, thanks. Well, it's an absolute pleasure to be here. I always feel like I'm a bit of an imposter because I'm not a GP. But I have worked in this area for a long time. So I'm one of the 3 Rebeccas that currently works at the 3 national think tanks, all of whom lead in general practice, all of whom are called Rebecca. But my name's Beccy Baird. I'm Senior Fellow at the King's Fund. I have been around the health and care system for about over 25 years now, have worked in the UK and in the US, in primary care in the US, and currently lead the King's Fund's work programme on general practice.
Thanks, Beccy. And Becks.
Hi everyone. It feels very strange being on a kind of different perspective as a Next Gen webinar participant. So most of you know me through Next Gen. It's lovely to see so many familiar faces in a different context tonight. I'm another Rebecca, Becks Fisher. I work for 2 days a week as a GP in somewhere called Blackbird Leys in Oxford, which is an amazing area of high urban deprivation in an otherwise pretty affluent city. And for 3 days a week, I'm Senior Policy Fellow at the Health Foundation. So it's kind of equivalent of Beccy at one of the other think tanks. I think they're kind of ethereal names, like Senior Policy Fellows. I think I wouldn't know what that means. And I think I struggle. My elevator pitch is terrible. But in brief, what I do is oversee a portfolio of work that looks across some of the big questions facing general practice. So what happens to funding? What happens to workforce? Thinking about particularly equity in general practice. And I work with people much cleverer than me to help answer some of the big questions.
Thank you both. And we're going to pick up on some of that experience and wisdom straight away. So tonight, everyone, we're going to try, we had a little chat to discuss how we might break this up. It's clearly a huge question to task ourselves with. And Beccy suggested breaking down the question and the answers into 3 sort of levels of of scale. So at the top level, we've got national and regional policy and the influences that those have on the way that we work and practice as GPs. If we go down a level, then we've got the role of practice and network factors, so more local within the sort of operational and also commissioning constraints that those create. And then at the sort of most granular level, we've got the lived reality of what it's like to be a GP. So there's sort of aspects of the way that the role is changing, regulation and you know, employment models and detail like that. So we're going to try and think about all of those three levels tonight, but we'll probably start at the top, as it were, and then move through them. And we know that different of you will have different levels of interest in each of those. So please do steer us in the direction that you would like to hear about, and we will be responsive to that, as well as trying to cover some of the big things that we think will be interesting and important over the next 5 to 10 years of work. Becks, I wonder if I could start with you, and just something quite broad, really. Could you sort of outline for us, with everything that's going on, when you look to the future over the next 5, 10 years, what do you think are the big moving pieces, the big influences that will shape the way general practice changes?
It's a nice, easy question to start with. Well, thank you. I should probably caveat this by saying that some of the things I'm going to say here are very much based on the knowledge and privilege I get from working at the Health Foundation, but they're not necessarily reflective of the views of the Health Foundation. So I'm very much here tonight in a kind of personal capacity as well, just to get that out there. I think there are a couple of big influences on change. I think there's the kind of background influences that are always present. So politics is really important. We are sort of slaves to political masters. That's an unpleasant phrase, but you know, the current government had manifesto commitments on 50 million GP appointments, 20,000, now 26,000 additional health professionals and 6,000 GPs. That is their priority in number 10. I've got another meeting with them next week on how they're going to deliver it. No matter what the rest of us think, there are kind of these prevailing winds. Others of those, I think, are things like tech, integration, what's going to happen to general practice at scale. Are we inexorably moving towards bigger and bigger practices? Or is there still space for smaller practices? So I think there are those sorts of things in the background as influences. Then I think fundamentally, one of the things that influences where we will be in the next 5 to 10 years is us, is the profession, is what GPs want and what we think is acceptable and what we think is best. And to a large extent, I think that's determined by what we hear from our patients and how we reflect that into the system and the ways that we work. So background influences and the profession, I think, are fundamental. And then I think, just to wrap up the answer, there are probably a few things that we have to have in the back of our minds as well. What are the constraints on change? And the things that I would have there are very much funding and workforce at the moment. I think they've been there for years and years, but I don't think we can overlook the bigger picture, and they're really quite challenging.
Thanks, Becks. It's interesting, the point to politics, which clearly is relevant, and we saw some of the rapid change in politics, in policy that emerged as soon as Matt Hancock took over as Secretary for Health, with suddenly the formation of NHSX and a greater focus on digital healthcare. But others might say that the job of the GP has been surprisingly constant through winds of political change over the last 70 odd years. Is there anything to suggest that that's likely to change, or do you think that actually some of those political machinations actually are less impactful than we sometimes think as we read the newspaper in the morning?
I think if the question is, do I think that my personal practice as a GP will change hugely in the next 5 to 10 years because of political factors? I think my answer to that is no. Like, I think for all of us, the core things, the clinical knowledge, the communication skills, the consultation skills, those things I think remain constant. But I also think that we are wise to pay attention to the political environment, because I do think it matters. And I think one of the things we have to do is pick out what are the really important things that will stick and stay as political priorities, and what are the fads. So Appy Hancock is full of tech. We all know that. But we all know that some of that tech will stay with us. Some of it is embedded into practice, and other things do come and go. That said, I think there are consistent political trends, and access is one of them. This is not the first government to really focus on access to general practice as a political priority. This government has realised that it's got a problem with trying to get GPs. It's made another manifesto commitment on them, which was, I think, a bold move. But it has also said, well, we're going to get 26,000 other allied health professionals to try and solve our problem of 50 million more appointments. And you'll notice that the wording is in general practice, not from GPs. So, but I think that we would be wise to pay attention to some of the trends and say, well, look, access is clearly a political priority, and then think about the implications for us as GPs. And certainly something that I've heard a lot of is in kind of meetings with government is an argument about the trade-off between access and continuity of care. And I'm sure Becky will want to come in on that as well. But I think that is something that will creep into my world as a practicing GP, because those things aren't mutually exclusive. You can't necessarily increase access in the way that I think this government wants to increase access without sacrificing degrees of continuity. Becky, I don't know if you agree.
Yeah, so I was going to build on that, saying, and just to build on that issue about political priority, because they're political priorities for a reason. And it's really marked with this particular government because they're a real populist government. So the reason they talk about access and the reason that that's a priority is because that's what the people who vote for them tell them is important. That's what they're hearing in their surgeries, in their MP surgeries, that's what they're hearing. And so that's why access becomes a political priority, because they think it makes them popular, and this is a particular populist government. So I think that's one of the reasons I don't think access will go away, because that's what the people receiving the service want. What I think we can influence, and I had my meeting with number 10 this week, Beck, so I might have to just we'll quickly catch up about that. Often we're in them together and WhatsApping each other frantically, but not this time. What they're interested in is what we can influence, and I think I think the Next Gen GP voice could be massively powerful here is how they do it. Like, what does access really mean? Because they don't know, and they really want to understand, what does it mean? What does it mean? What does good access really mean for people? Are we talking about lots and lots of 1, 2, 3, 10-minute appointments, or actually are we talking about the right length of appointment for the right person at the right time with the right professional? How do we think about team working, which I'll talk about, because I seem to talk about that a lot at the moment. So I think we have to pay attention to the political priorities, because that's not going to go away, because they tend to be driven by what's the prevailing mood in the country. And we know that issue of access hasn't gone away in years and years. We can see that in the GP patient survey, for example. But I do agree with Bex, absolutely, how it's implemented is absolutely critical. I mean, I have some thoughts about some of the other stuff that's driving some of the change in what we'll see at the moment. I think I agree we need to pay attention to digital, because we know that we're moving towards that more digital age. What does that mean in terms of, again, how it's implemented? It's not about whether digital is good or bad. It's when is it good, when is it not good, and how do you best implement it so you don't increase health inequalities, you don't do all that sort of thing. So the implementation becomes incredibly important at that point, and trying to learn those lessons. I think the prevailing winds in the health system very much at the moment, and to be fair, have been over a fairly long time, is this thing about integrated care. And what does that really mean? What does it mean to integrate hospitals and primary care? How do we make sure primary care voice doesn't get lost in the kind of in the maelstrom that is acute care, particularly at the moment? And that's going to be even more important, I think, over the next 5 to 10 years as the hospitals emerge out of crisis. How do we make sure that general practice is still, we think about this as a whole system problem, not as a hospital community general practice problem. I think that's going to be something to pay attention to. And I also think the other influence that's coming up that we're seeing in terms of trend is an increasing focus on community. So really thinking about what does it mean to co-produce services? What does it mean to reach into communities and to listen to communities? What does it mean to use community assets to help people live more fulfilling lives? And that noise has been around for a while, this sense of community health. But I think it's absolutely growing at the moment, and places like Wigan and Fleetwood and other places in the country who have kind of gone quite a long way down that, and the Grenfell experience as well has led them to create some really interesting movements at that kind of grassroots level. And I think that's going to be something that GPs can play an amazing part in, because they are right there in neighbourhoods, they're right there, they understand communities, and they're very local. So I think it's, yes, there's this kind of big integration, big system kind of stuff going on, but I also think there's some stuff that's really interesting going on at this very granular level, which is something I think will really influence how the system thinks about health and care. And again, I agree with Becks. Do I think it will change how you as individual GPs practice? At its basis, no, because your basic skills and the basic, what is a GP has remained the same for a long time, and that's a really good thing. There's so much to value. But I do think the system around you is going to change, and how we flex and morph with that change, and also make sure that we can influence it so it goes in the right direction, is really important.
Thank you both. That's such a useful place to start. So we've thought about some of the big winds of change and influence there. I'd like to stick on the politics just for a moment, because I think it's really fascinating. And as you've both alluded to, you have a different insight to the politics behind some of these changes than most of us. So just a sort of personal, practical question for those of us who are still learning what think tanks do on a day-to-day basis. When you go to these meetings, what's your role, and how do you see your role and sort of your aims for that interaction? Becky, we start with you.
Yeah, sure. And actually, I have a GP trainee registrar who works with me all the time. So we have one on rotation every 6 months. I've currently got an ST1 Armena who's amazing, working with me as an ITP for the part of the Imperial scheme at the moment. And so she came with me to shadow me on this meeting, and she asked, we kind of did a debrief afterwards. So I'll tell you what I told her, which is, so I'm going into those meetings knowing that I'm incredibly privileged and position of some power. I also know that I'm not the only person that that the team are talking to. I know they'll talk to Becks. I know they'll be talking to loads of other stakeholders. So my job is to raise issues that I think is important for them to consider. What I'm not going to say is, don't do that, that's stupid. It's so tempting. It's so tempting sometimes just to say, are you kidding me? And there have been on the odd occasion when I might have done that. But generally, it's to say, the team I've been talking to at Number 10, they're doing what their political masters are telling them. They're trying to implement what the government's manifesto have said, that they need to find solutions. So what my job is to make them do what they need to do in a way that is the least harmful possible, and that they avoid some of the traps that I think they could easily fall into. So I have in my mind a do no harm kind of perspective before I start those meetings. There are things I know about and there are things I don't know about. I'm not a clinician, and I know that. What I know about is what the evidence tells me. So I make sure that when I'm talking to them, I'm really clear about what evidence I'm using and about why I say what I'm saying. So if I'm saying to them, I think access targets are a really silly idea, and I do, I can tell them why, but I can also think about, so you might want to think about thinking about staff satisfaction as a really good proxy of so a combination for me of staff satisfaction and patient satisfaction is normally a very good proxy of how well a service is working. So why not think about that? And you raise some of those thoughts, and they generally want to be open and hear. So I'm not a lobbyist, that's not what I do. I'm a researcher, I'm using the evidence, and I'm using the networks I've got, and I'm using what I'm hearing, and I'm not arrogant enough to think that I've got all, if any, of the answers. But what I want to do is get them to think and get them to avoid the things that I think will be most harmful. Becks, what do you reckon? So Becks and I are often in these meetings together, and there have been points where it's just as well nobody can read our WhatsApps because they can get quite desperate. But yes.
Everything being online now, it makes it easier to share sort of horrified WhatsApps than it was when you were in person.
Yes.
Just trying to look someone's eyes and think, my God, are we on the same page here and thinking this is like off the wall? So just to zoom out slightly, like I got into this line of work because I think I was fundamentally interested in the question at the root of this, which is how does change happen in a healthcare system? And for me personally, I was interested in what are the mechanisms for making change outside electoral politics? Because I was asking myself whether I wanted to be a politician, fundamentally and frankly. And doing this job has certainly given me a sort of fascinating insight into the way that some, I definitely don't have as wide an angle lens as I would sometimes like to, but some influences shape government. And I think there are sort of two significant ways in which we at the Health Foundation interact with government. One is policy analysis, so looking at government policy and reflecting on it and picking it apart and saying what we think is good and what we think could be better. And we often do that by looking historically. So for at the moment, many of you will know my chief interest in life is equity, and particularly equity and improving equity in general practice. So at the moment, I'm doing a piece of work looking back at all policies that have tried to change the inverse care law since 1990 and saying what was tried, what worked, what didn't work. And we'll use that to do the second thing, which is what we would call policy development, which is to say to anyone who will listen, and this is what we think you should do. And I think the kind of what goes on in those meetings question depends very much on how the meeting is set up. But fundamentally, at least my understanding of it is that there will be a ministerial decision or a manifesto commitment that government wants, and they will have then said to the civil service, go work out how to deliver this. And at that point, Becky, jump in if you don't think this is kind of accurate and reflective. At that point, the civil service will usually reach out to people who they think can help them answer that question. And so that's usually when we get roped in. So we get an email saying, can you come and talk with us about X, Y, or Z? And that's that form. And the other way that they happen is because we have kind of pushed in a way. So for example, with the equity stuff, this government is not hugely interested in, I would say, improving equity in general practice, but it is very interested in keeping the votes of the red wall. So that's a lever that I can depress to say, look, this is why actually improving equity in general practice matters, because this is the funding gap between practices behind your red wall constituencies. And this is why you're going to have a problem improving access if you don't first improve the workforce, and actually improving workforce is fundamentally contingent on funding. So I guess it is a real blend of trying to mesh our individual interests for people like Becky and I with our organisational interests, the King's Fund, the Health Foundation, with what we know government are interested in and how we can meet in the middle of all of those things.
And meeting in the middle feels really important at times as well. And it's also understanding the pressures that the civil servants are under and the constraints within which they operate. As Beck said, they're coming to do a job, and they'll reach out to people like us because they need people who will, they need to talk to people who will give them the answers to an extent, but will also challenge them and be a critical friend is often how we feel like we're at. So we're gonna challenge. We're not going to just say no, but we want to be helpful as possible, but equally we're still going to stick to the things that are fundamental to us. So for the King's Fund at the moment, so a lot of my work recently has been about team working and new roles and that kind of thing. So a lot of the things I will be talking to them about is how do you best implement these policies around new roles, or I might be talking about mental health, or I might be talking about whatever issue it is that we've got some research on. Some of it will be because I'm doing that research in response to what they want to look at. Some of it will be because we've done the research and we think it's really important. As Beck says, we're looking at those policies. So policy analysis, policy development, and working with them and kind of nudging and negotiating with them all the time to try and come alongside them to make it as good as possible. And there's some brilliant people who work in these very tough roles, even so sometimes they make decisions that you think are the most ludicrous thing. They're working in there, they're doing the job the best they can, and my job to do the best job I can is to help them do the best job that they can possibly do and have access to all of the evidence available to them.
Thank you both. Becky, we are certainly going to pick up more on the influence and practicalities of some of the changes in roles and new roles and the way that we work together. I'm going to echo Sam's appreciation to you both for at least being two people who represent the importance of evidence in policy making to government. Thank you for that. And Sam was also asking, given the heterogeneity of general practice, the stark differences faced by practices in urban versus rural settings, areas of relative wealth versus deprivation, how do you take those nuances into account when crafting national policy or helping shape national policy?
Do you want to take the Becks, or shall I
should
start?
say who I actually. Well, Becky, you were in your place.
So I spend an awful lot of time talking about the fact that you can't have a blanket solution for everywhere in the country, because you're absolutely right. General practice in the middle of Sheffield looks so different to general practice in rural Hertfordshire or wherever it is. And actually the power of general practice is that is exactly that flexibility and the ability to respond to the needs of your registered patient list. That's exactly what you're best at doing. And I think a lot of what we are trying to influence at the moment is to make sure that in national policy terms, the way that those national policies are implemented allows the flexibility to reflect the different needs of different places. Now, that doesn't work very well in lots of areas. So Becks does a huge amount of work on this, and I won't talk about it too much because she knows way more than I do. But the funding formula is rubbish at representing deprivation at the moment. We know that it doesn't reflect deprivation well at all. And so that makes it really hard to implement some of these policies in more deprived areas, because it just costs more to do so, and they don't have the money to do it for lots of different reasons. And that's a way oversimplification. So we will try and influence government to think through some of these unintended consequences for the policies that they're putting in place if they try and put out a blanket policy. So Becks and I did some work last year, I think, on the effect of the new PCN contract on practices in working with deprived populations, and tried to influence some change in that to try and make some of the things that were happening less difficult for people working in deprived areas. And we had we worked with lots and lots of other GPs and people from around the country, but we did have some success with making some changes around that. But it's keeping that going, keeping that kind of constant. Please don't think that you can have a single solution for the whole of general practice in most areas.
Thank you, Becky. I did want to pick up with you, Becks, how you see this struggle for greater equity and access in general practice. There are a range of, in terms of outcomes and access and all those other metrics that we might use, because I know it's something you've thought a lot about. It feels pretty core to what it means to be a GP and to be a healthcare professional, that we would seek that. And I know lots of people in this group do a lot of incredibly important sort of grassroots work. Rachel Steen supporting the Fair Health program. So, but from your perspective, Becks, what do you see as how optimistic do you feel, and what needs to happen to realise your vision for greater equity in the way you describe?
I think how optimistic I feel varies day to day based on sort of the contents of my inbox, and there are definitely days where I want to bang my head against a brick wall, but we all have that, don't we? And look, the way I view this is that it's a shoulders to a door thing, particularly with the funding formula at the moment. And I am one of many people putting a shoulder to a door, and the more shoulders the better, and at some point it is going to give. And I don't know whether it will be kind of me and our generation who managed to achieve that, or someone else's, but I want my shoulder to be on the door with others at the moment. In terms of how I see my role and the equity question, I am interested in what we would call supply side factors. So in this context, the two things I'm most interested in are funding for general practice and how you make that fair. So there's a really important distinction here between equal and equitable. And in my view, NHS England's policy, but before NHSE, DHSC, has been things should be equal. So we should give things fairly. And we're seeing this again with the vaccine at the moment. We're going to give this fairly to all 80-year-olds. But what is equal isn't equitable. It's not fair. It's not based on need. And so my kind of driving motivation is to increase equity in general practice. So to give resource in proportion to need. And I think there are loads of different ways that we can approach that problem of how we generate better equity in general practice. And people on this call have loads of ideas. Within your practice, there are loads of things you can do to make the care that you're giving to your practice population more equitable. I guess in my policy job at the foundation, I'm really fortunate to be able to zoom out to the really big picture and say, what do I think the biggest barriers are on equity in general practice at the moment? And there are two of them. There's funding and there's workforce. So if we look first at funding, and it partly answers your question about heterogeneity as well, is I do research, and some of that I do myself, but a lot I get people who are better equipped than I am to answer these questions. So for example, on a paper we recently published, I worked with health economists to basically look at the inverse care law in England and say, to what extent does this exist in 2020? And what we find is that practices in the most deprived areas, once you adjust for need, get about 7% less funding than practices in more affluent areas. When you look at workforce, if you're a GP working in a deprived area, you're going to be responsible for about 10% more patients than a GP working in an affluent area. And everyone on this call will know that if you're looking after patients in a deprived area, they are going to have more long-term health conditions. So you have less resource for greater need. And so my kind of hobby horse is trying to change those supply side factors, trying to create arguments to force, I mean, realistically, we need both government and arm's length bodies, in this case, NHS England and Improvement, and the BMA, because you have to think about, well, who are all the players in this picture? Who has control of the funding formula? Who has control of where workforce go? And then work out how you influence them. I guess in my head, I view it a bit like a chessboard. Like, who are the players on this chessboard, and how do they need to move for change to happen? And then what can I do to help those pieces move? What do other people need to do? And Becky and I work closely on this. When we were worried, for example, when the first PCN kind of DES came out, that PCNs were paradoxically going to widen health inequalities, Becky and I got together to bring together a series of roundtables, which we hosted at the foundation. We drafted kind of notes from that very quickly, and they went quietly to NHS England. So we're always kind of thinking, what are the ways that we can draw together our knowledge to influence on things that we think are important? Sorry, it was a bit of a ramble through, but
no, really useful actually, Becks, and interesting to hear you kind of talking about that kind of soft persuasion that, you know, as so often the case, I think influencing policy is much less from banging the drum in disagreement and much more from, as Becky talked about, getting alongside and nudging. And I think it comes a bit, Shivan's asked about how you manage when your own political views differ quite significantly with the policy you're trying to influence. But I guess that's probably not that uncommon. And I think that you've both given us a bit of a suggestion as to how you do that.
And then I'm not a civil servant, which is another thing, because I don't think I could go that far. So I think it's, yeah, the civil servants have a much tougher job doing that than I have to. But the think tanks are neutral. So we work on the evidence.
Yeah, perfect. There are some interesting questions for you about how you as individuals deal with the job. And there are some really, I want to come back to Sonali's question, which is around the independent contractor status of general practice. Just before, I'm going to give us a 5-minute break to stretch legs in a moment. But before we do that, Elizabeth messaged me with a question. And I just wanted to ask if Elizabeth would come off mute and ask it yourself, because I think she will, I won't do it justice. Elizabeth, would that be okay?
Okay, so it's a 2-part question. Thanks for explaining how the prevailing winds can affect our context. Do you, in your experience or in the experience of your predecessors, do you see any effect on the changes in government or changes in health secretaries and how the workforce issues in particular are addressed? And I guess the second part is, you know, there's been this surge of public appreciation for healthcare workers. How do you think the post-COVID climate will influence how workforce issues are addressed or prioritized?
Thanks, Elizabeth. Bex, can we come to you on that tricky question?
It's a really good question. I don't have an immediately good answer to it, but I'm sure I'll think of a better one at about 11 p.m. tonight. So thank you, Elizabeth. Your question about changes in government. Yes, I think someone I think in the chat, it was in my peripheral vision, was asking kind of, would things be different under a Labour government? And I think, look, clearly governments of different political persuasions will have very different takes on some areas of health policy. And I think, importantly, we should think about health in the round here. So there's policy as relates to the NHS, and then there's policy as relates to the social determinants of health, which, as we all know, actually have more of an impact on health than healthcare itself does. And so governments of different political persuasions will put different amounts of money into things like children's centres and early years education and smoking cessation and all of the things that we know actually really matter if you want a healthy society. That then differs from what happens at the Department of Health, now the Department of Health and Social Care. And I think there, Becky, I don't know what you would say. Look, I think priorities change less. They have a narrower bandwidth.
Yeah.
And that's partly because the remit is smaller, because the remit of what you can do in the NHS is more narrow. That said, I think there have been changes. So if we look back, for example, to 1990, the focus there was on competition. Competition was the big new thing in the NHS, and the way we were going to make progress was by making everyone compete with each other. So you become a foundation trust and you would compete with your neighbouring foundation trust for money and resource. And the way that we paid for things in the NHS has changed over time, and the way that we buy health services that we commission has changed over time. And the arc of change is towards collaboration. And we can talk in more detail if you want about the new kind of legislative changes in the NHS, but I think generally the arc in the last 20 years has been from competition towards collaboration. To answer your specific question on workforce, Elizabeth, I don't think that it has changed hugely. I think that there has been a well-acknowledged problem with the general practice workforce specifically for a long, long time now. I don't think that there have been
a well-acknowledged problem.
Just with GP numbers, Will. Like I think it's been quite clear for a long time that we haven't had as many GPs as we need, fundamentally, and access has been a big political target in general practice. Like in the early 2010s, we had the Prime Minister's Access Fund, Challenge Fund, which was for projects on access. Like fundamentally, access and workforce, I think, have been problems that have plagued general practice for, I don't know, 15 years. Becky, do you think that's fair?
Yeah, probably more than that. So my first job in the NHS was 1994. So I've been through a few governments now, and I think you're right. I think there's an arc of change, and actually, interestingly, if you think about it from competition to collaboration, given we've got a Conservative right-wing government at the moment, that's not the way you'd have thought it would have gone. I think some of the flow has just kind of happened naturally, and it's things that were happening in the health service, and it kind of happens in waves. I do think things like austerity have a much bigger impact actually on health than some of the particular policies within the health and social care system. So it's less about who's in the Secretary of State for Health job and more about where the government's at. I think on workforce, this has been a problem. I can't even tell you how long not having enough GPs has been around as an issue, and I've got to the point I don't really understand why anymore. I think there's something. I think it's a really, really wickedly difficult issue because I think it's tied up with some stuff within the profession itself. So that's about how many people want to be GPs, how are GPs valued, how many people are we putting into medical school? Are we putting the right people into medical school who've got the right kind of background, who want to be GPs? All of that kind of stuff goes on, plus enough money to train and support them, and then enough money to give them satisfying and fulfilling jobs at the end of it. So we know in Germany, for example, where they're much higher doctor numbers, they're paid a lot less. So we really got to think about how that works. And I think I do think that, the combination of Brexit and a kind of insular looking government is not going to help us in terms of workforce, because it stifles our ability to grow a great workforce. So I I find the workforce issue one of the most complicated to look at, particularly the GP workforce issue. I'm happier talking about the other bits of the workforce because I honestly, it doesn't appear to be easily solvable, and I don't fully understand all the barriers, particularly on the profession side.
Okay. It was a great question, Elizabeth. We didn't quite get into how COVID will change that, but I think, judging, based on what Becks and Becky have said, there's a huge lead time to any change, and it doesn't feel like the most optimistic note I wanted to end on, but it's a very honest note. We're going to have a Becks, sorry, yeah, just before we break.
I want to just try and do an optimistic note here, which is I think the workforce problem in part gets solved by you guys, because fundamentally what we need to do is we need to translate the higher numbers that we're seeing in GP training at the moment into GPs, into people who want to work in general practice, into people who see it as a fantastic, fulfilling career. And so part of this is what we do collectively to make it that.
Brilliant, thank you.
I don't think this is necessarily a problem that gets solved by government. I think this is a problem that we collectively as a profession need to solve, and it's in our best interests to do that.
Yeah. Thank you. So we're not finishing now, everybody. We're just going to have 5 minutes to stretch legs. So if you could be back with us by 20 past, we're going to be starting on 20 past. Grab a drink, go to the toilet, and we will see you in a second to pick up some more of these excellent questions. Thank you. There's that little awkward thing now, and no one quite knows what to do, but feel free to turn your screens off if you need to, but we will be back very shortly. Oh, Becks, welcome back. You're suddenly very bright. Have you? You're illuminated in a new way. Oh, and on mute in classic 2021 style. Sorry.
Oh yeah, that was my safety check, Will.
Oh yeah, well done. We've just seen we've got some really brilliant questions coming through.
Yeah, they're great, aren't they?
Yeah, it's really hard not to get distracted by them because they're so good. I just kind of want to dive straight in.
I think as we get people back for the next part, I think that's what we're going to do. We're going to start diving into people's questions and just go with the flow rather than sort of pushing on. Lots of people still want to find out more about your experiences at this sort of national policy level, and I completely understand why. You both talk so brilliantly about it. I think we'll probably move through some questions, and then we can, always find another day to talk about that, can't we? And I say signing you both up to it. No, I'm joking, but we've got to. I'd like to hit on some of the questions as people start to come back to join us. I'm just going to check on the other view. We start as people's cameras start to come back on, and I know they're with us. Perfect. Hey, Sonali, sorry to bother you in your kitchen. I wondered if you'd mind asking your question, because I thought it was a really good one to move us on.
No, thanks. I was just getting my dinner ready. So great to hear from you, Becks and Becky. Really interesting. So I'm wondering. I think it's about the independent contractor question that you were probably alluding to, Will. And just wanted to get your views on that. Becks, completely agree. The answer regarding workforce and retention lies very much within us. And probably related to that, I will ask the question with regards to independent contractor status. It's good for things, but it's not good for so many other things. We don't have, if you look at our nurses, we don't have agenda for change. So there is variation in what the nurses get paid. We know there is a gender pay gap up to 33%, they're saying now in general practice. We don't have access to occupational health. We don't have some of the good things probably that will come through people's plan, because everybody then says, it's just too hard. It's the independent contractors that the general practice will just go on to do the 7,600 practices that we've got in the country. Who is going to bring change in those 7,600 practices? So I just wanted to get your view on it. Does the model of independent contractor state work for now that lots of our workforce wants to be portfolio or wants to be maybe in an employed status? Does it really work? Has it served its purpose, and should we be looking at something else?
$1 million question, Sonali. So I think the first thing I would look at is primary care networks, and there your answer can be cut either way, because I think they're either a vehicle for the salvation of the independent contractor model or its destruction. And what I mean by that is you will all know that primary care networks, so groups of general practices working together to cover 30 to 50,000, they're the first mechanism for sharing funds between general practices that we've ever had, really, that requires partners to literally pool a proportion of their funding to deliver a set of services at a level that is greater than the individual practice. I remember speaking to Ian Dodge, who's the kind of architect of this, and this is kind of off record, if that's okay, at NHS England when the kind of PCN stuff was first happening. And I said to him, look, is this just a backdoor way to get rid of the partnership model? You create PCNs, okay, they're not legally organizations at the moment, but you drive some legislation through, and this will happen next year. This particular bit of legislation isn't tacked to it, but it wouldn't be difficult to do, that allows primary care networks to become organizations. And at that point, you have created a superstructure above general practice that can be a lead employer. Someone wave at me if I'm not making sense, but I think you get the idea. You've created a structure, and we now have those in place. Almost all practices in England are part of a primary care network, and all you would have to do would be to change legislation slightly to create a situation where you got rid of the partnership model. But Ian's answer was that he actually saw primary care networks as the salvation of the partnership model, because he said they will basically rescue general practice because people don't want to take on the responsibility of partnership. You need more workforce, you need action on workload. We view the additional allied health professionals as the solution to that. And so we think that this is a way that we can actually shore up general practice and allow the survival of the partnership model. I kind of leave you guys to make your own conclusions. And I think that this comes back to the question of heterogeneity in general practices as well. In some areas, the partnership model works really well, and there are strong local partnerships with GPs across a range of ages, giving security and stability. In other areas, that really does not exist. And the partnership model is looking very, very precarious. One thing that I would also add into this, Sonali, and I don't know, be interested to hear your thoughts on this as well, is single-handed general practice. I think we know, for example, that general practice in areas of high deprivation, like single-handed general practice is far, far more common in areas of urban high deprivation. I did some work earlier this summer just looking at the risk to individual GPs from COVID, and a significant number of our single-handed GP colleagues are at higher COVID risk. They tend to be older, Black and minority ethnic GPs who are themselves at higher risk, serving inner city deprived populations. And so we have very real, I think, issues related to the precarious nature of single-handed general practice at the moment, particularly because of the communities that it serves.
So I might build on that if I can, and just I was looking at another question that was popping up about, is this just a fad, the PCM model? It's very hard to say that another government won't reverse things, because you can never predict what they will do. But I actually think that this sense of a kind of a bigger network level, it makes sense to me. And actually I was really interested, and there's more work needs to understand how much this has happened, but during COVID you can see so much of practices coming together, whether it's to do a hot hub or to do a vaccine or to do whatever it is. That some of that's been driven because that's the way the funding has flowed, but otherwise it's because partnership makes it easier to do these things at scale. One of the things I think, if a PCN works well, and I work with PCNs all over the country, I do quite a lot of OD work. I'm a coach as well, so I work with the King's Fund has a kind of leadership and organisational development branch. So my colleagues and I do quite a lot of kind of on the ground work with practices all over the country. And where I've seen the highest functioning PCNs, it's where they've got a really good, strong PCN strategy. They have a real good sense of where they're going as a group, but they retain their autonomy as practices. And so you've got the benefit of these kind of great practices who kind of represent a particular, whether it's a little village because the surgery's in a village, or whether it's in a particular area of a town that has very different needs to another area. They can serve the needs of those patients, but can also use the benefits of scale and come together. But it's a huge task to do. It takes masses of relationship building, loads of work through conflicts and all that kind of stuff. So I think primary care networks are really quite exciting. I don't think they'll replace the partnership model, because I think even a primary care network can't do the nuance that general individual practices can do. And I think even in those really big practices that we see, there's still a sense of kind of branch surgeries and really thinking about local level population. So I think it's still really important to think about how we balance all of that stuff. But for me, they may be a way of helping get more resource into general practice and to shore up general practice to a certain extent. And that balance between, how much are we asking, how much are we expecting of primary care networks? I think too much has been expected in the past. I think that's being rolled back a bit now, which is good, but it could be really exciting.
Can I just add, sorry, a couple of quick thoughts that occurred. One thing that I find challenging related to the partnership model in policy terms is that an accusation that commonly gets levelled in sort of meetings with government, etc., is, well, if I give that money to general practice, it will just line the pockets of partners. Sad to say, but that is a very common refrain in political land. So, you know, I say, well, you should give more money to practices in areas of high deprivation, and people say, well, show me how that will improve outcomes. You've got no evidence that will improve outcomes for patients. That will just go to profits for partners. So that is just an argument that we come up against. The flip side of that, I think, is that we all know that there is a huge amount of discretionary labour that goes on in general practice that isn't paid for officially. I would also not want to make the case, so I'm a salaried GP. I think that there are plenty of people who work as salaried GPs and sessional GPs who contribute in ways to the practice and the community that go beyond our traditional expectation that it is only partners who play a role in the management and sort of wider functioning of a practice. So just a couple of extra points to kind of add nuance. I think the bottom line is, we had a meeting of the three Rebeccas recently to try and talk about this, because it is super complex, and I certainly don't have I think the partnership model will survive the next 5 years.
Yeah.
I personally have stronger views on single-handed general practice and whether that should survive than I do on the partnership model.
I think you guys need a better team name than the three Rebeccas, but you give yourself thank you both. Yeah, it's really interesting, isn't it? I get sucked into this on Twitter sometimes. People say, well, the PCNs will be the death of small partnerships, but one can definitely see a situation in which they are a salvation of sorts as well. It must depend on the relationships and the way you develop those kind of cross dependencies, mustn't it? It'll be really interesting to see how they evolve. Sam pointing out that of course they are distinct, and his own PCN is one partnership, but that will be different for lots of people. I think interesting, Becky, to hear your kind of reminder that this, whatever scale, the sort of the small unit or the local unit remains important. As you say, I think I'm in a 20,000 patient practice now, and our branch practices remain fairly autonomous. They still have a really strong identity. So I think that'll be interesting to see how it plays out. Can we move to Sarah Invine mentioned an announcement this evening on the NHSE webinar about increased funding for PCN CDs, which I'm sure we all agree is welcome given the extraordinary amount of work that you've all been doing over the last year plus. But it's an interesting kind of interesting challenge around recognizing the wider team. We do, lots of places do now have new roles, new to general practice roles, at least, physicians associates, paramedics, many more pharmacists coming into the practice, AMPs and all sorts of specialist nursing roles, and many others, social prescribing link workers, and a whole host of others that you will be able to name more than I can. But I wondered just if you could give us, from your perspective, we've talked about whether PCNs will stay or be a fad. That was really helpful. How do you see the GP team looking, the general practice, the primary care team looking in 5 years? With the caveat that there will be huge heterogeneity. So maybe, what do you see as the sort of range of normal if we kind of look back to this conversation in a few years' time?
So I kick off. I do a lot of my research in this area at the moment. So I feel like I spend a lot of time talking about teams. I think that the future of general practice is a team. And I think I have been surprised in some of the research I've been doing, particularly this year, in how siloed general practice often can be. And I'm saying that really cautiously, because again, masses of difference, and there's some people that don't. But when we were doing some research on remote working recently, we found lots of people would talk about a WhatsApp group between the doctors, a WhatsApp group among the nurses, a WhatsApp group for the admin staff, a WhatsApp group for the pharmacists, but much less about the whole team. And when we did research at the King's Fund a couple of years ago on sort of international models of general practice, I was kind of interested in what were other countries doing in response to all the pressures that were facing primary care, and how were they responding to the workforce crisis? The workforce crisis in primary care is not unique to the UK at all. It's absolutely common across many other countries. So what were they doing? And they were really thinking about a different model for primary care that really thought about team, and that might often be a micro team, so a GP working alongside a nurse case manager, working alongside with an admin person, with a kind of physician healthcare associate type person who would manage maybe 1,000 patients between them, a bit like an individual list. As a group, maybe some cross covering with extra roles coming in around the side. I write a lot about the NUCA model in Alaska, which uses that kind of model. And we've seen various attempts at that in the UK, this kind of small team model, bringing in different professions. What we're seeing in the PCNs that are really making the best use of these new roles coming in is that they don't have a new person come in, show them the office, shut the door and let them sit there and just send them tasks. That there's a better way of huddling, about sharing of information, about really understanding who's doing what for which patient when. It's not just about creating extra silos and extra bodies within the practice. It's really changing the way in which the workload flows and the work happens between the team. And I think that's quite exciting, but that is quite different in many ways. And I think that will be something to really explore and think about. If we've got all this new money and these new roles coming into general practice, what's the way of making them really work well and really serving our patients? And also, frankly, what's the way we can retain these new roles? Because if you've got a pharmacist doing 2 hours in one practice, 2 hours in another, 2 hours in another, or a day a week in different practices, it's not a satisfying or fulfilling job. We need to think about how we absorb that team together and really think about it as a whole way of approaching patients.
Thanks, Becky. Bex, did you have anything to add to that?
To take it down a slightly different tangent, because I think Becky has covered that so beautifully and much better than I could. Two things so I completely agree. We will be working in an MDT in 5 or 10 years. A couple of things that sort of play on my mind about it. One, equity, of course. I am really, really worried that so in the PCN contracts, there is nothing to level the playing field for recruitment. It's basically a free-for-all. And others on this call will have had the same experience. So we had a pharmacist and a paramedic working in our practice 18 months ago. We lost them to the PCN down the road who could afford to pay more. We've now managed to recruit a paramedic, but we haven't recruited another pharmacist to replace the one we lost. My real worry is that we will see replicated across PCNs what we see in the general practice workforce now, which is that the additional workforce will go to the most affluent areas and the most deprived areas will be left further and further behind. And I think unless you proactively put mechanisms into policy to stop that happening, that is what will happen. And that's because practices in more affluent areas are relatively overfunded. They can afford to pay more in salaries. And also lots of factors determine why people choose to live and work in more affluent areas. So I think the equity angle is really important. And unfortunately, it is playing out like that. So back to your question about heterogeneity from earlier, something that you do if you're in my position is you research it. And so we did something called latent class analysis, looking across all primary care networks and grouping them into 4 different classes based on whether they were, for example, urban, rural, urban affluent, rural deprived, whatever. And what we did when we looked at workforce with that was to say, well, where are the workforce going? And lo and behold, and this is only on a year of PCN recruitment, but it's the first year, what we're seeing already is that social prescribing link workers and pharmacists, the 2 bands who were allowed to be employed right from the beginning of the DES, have gone to the more affluent PCNs over the more deprived urban PCNs. So that really worries me. The second thing that I'm interested in is what happens to continuity of care. And we funded at the Health Foundation a group of researchers at the University of Manchester to do a 3-year longitudinal study looking at what the effect of the new MDT through PCNs will be on continuity of care. Now, clearly, all of this depends on how many of the new MDT actually show up. I am yet to be convinced, as I'm sure are lots of you, that 26,000 of them exist and NHS England were never able to produce or willing to produce. They may have it, but I never saw, Becky. I suspect you didn't see either, but I'm sure you asked as well, the modelling of how they're going to get that many allied health professionals. So I think a lot of people who have looked at PCNs have raised the same concerns about equity and about deliverability, because fundamentally, the degree to which PCNs will alleviate the workforce and workload pressures in general practice will depend on whether or not this allied health professional workforce kind of are the cavalry coming to rescue us, or whether they don't exist at all or go to somewhere else in the system. And of course, magnifying this now is COVID, which is creating lots of other pressures and demands on where those people might spend their time.
Thank you. It ties in a bit to Elizabeth's point, which was, will COVID and the sort of change in appreciation for healthcare workers influence that? I was listening on the radio, they were saying to some people who are responsible for recruitment in different organisations. They would say the number of people applying to be teachers, for example, is much higher this year. I mean, I'm surprising given how hard we now all know teaching is with homeschooling and whatnot. But I wonder whether we'll see that coming through for healthcare professionals, although I guess there's at least a few years lag for that.
The argument that Becky and I had in the summer with they had a number 10 task force on looking at yeah, maybe can we not tweet about this? Yes, please don't. There was a number 10 task force looking at retention in general practice, and both Becky and I were asked to participate in some of the thinking around that. And one of the things that there were lots of ideas on the table, but what wasn't on the table was why the contribution of general practice to the pandemic effort thus far hadn't been mentioned, why there weren't GPs in the number 10 briefings, why it was all hospitals. And Becky and I and a couple of others were there saying, look, you have to acknowledge the contribution of general practice. You can't just say this is all acute, like this contributes to the same workforce problem that you're simultaneously trying to solve. This is ridiculous. Don't invite GPs for breakfast at Buckingham Palace and simultaneously say that they're not doing anything in a pandemic. It's a kind of, and I think unfortunately that is still going on, and is messaging that I know that I think I can speak for us both in saying we have tried to call out, and I know that others at NHS England really try hard to call out as well.
Yeah, I think I think the 26,000, you're right, there's no, the modelling is, I've never seen it, and initially the decision about which roles will be funded was based on national assumptions about national supply, which of course makes absolutely no sense in different areas of the country. So like, I know in Humberside, because the local university doesn't have a pharmacy degree, they've got a real shortage of pharmacists because people don't stay and work. And so thinking that there's a massive supply of pharmacists, that might be true, but they're not evenly spread across the country. And as Beck said, they don't necessarily all want to work in the same area. So I'm glad that their roles that are being funded under the IRS are expanding. I'll be even more glad if a mental health role comes on, because I think that's something that people are desperate for. If I hear that more than anything else from people in the system, that they want to be able to fund mental health workers. So I'm hopeful that by extending the roles available, people will be able to recruit to what they think they need and also what they can get. So those two things will hopefully happen. But I think there's a lot to do, and I definitely echo that this issue around the level playing field. There's a lot of work to do on that, especially as we come out of COVID, because I think there's been a bit of a pause in recruitment because people haven't got the headspace at the moment. But as we're coming out of it, I think it'll be really really important to watch that and to really pay close attention to it.
It's really great to see as well in the comments, Hannah Morgan showing her view, living in a fairly affluent part of quite a varied borough, it sounds like, with areas of significant deprivation. Really great that it sounds like you're trying to work together across that higher scale to ensure you don't worsen that. Hannah, do you want to come on quickly and just tell us a bit what that's looked like?
Yeah, so I work in Havant, which is one of the most deprived boroughs in Hampshire Isle of Wight, which is well known to be a more affluent area of the country. And traditionally, people think of Portsmouth as very deprived, but they forget that Havant is there. So in our borough, we have, I think it's something like 3 of the top 5 most deprived parts of Hampshire Isle of Wight. And people have very much not remembered that. So since PTN started, it's very much been kind of banging of that drum, really, across but for historical reasons, when we started as networks, just people wouldn't play with each other at all. So we ended up with, instead of a sensible geographical distribution, it ended up with who people wanted to work with and who they could get on with, and almost like a wedding cake of in the very deprived areas of 2 different PCNs. And actually over COVID, we've had a very thorough collaborative approach, and it's been amazing with the vaccination programme. So we've got 3 sites, but across, so 11 practices can go into any site, which has been really good. So we've been able to get loads of vaccine because our area's got loads of over 80s, but the more deprived PCNs that don't have many over 80s, we've also been able to share our vaccine. We've been able to share the vaccine, which has been really good. But the hard thing is that we've been able to recruit really easily. because we live in a nice, it's a nice area. We very much have two communities which are thriving as practices. The other PCNs, the clinical CD, the CDs, have just been working really hard. So their GPs are leaving. They were falling over before COVID. So they're, instead of being able to spend time recruiting, they've been doing clinical sessions during their CD sessions. So then they just don't have the headspace. So actually it's really played out what Becks and Becky have been talking about. You can really see it playing out. But I think what's been really good in COVID is just been to build the relationships, to be able to say, oh, actually, this is how we've been able to recruit. And actually, we've just recruited some care coordinators. Do you want the interview list of the people, and I think it has really helped that bit. But one thing that I wanted to ask was about working in partnership. So for lots of these new roles, I found like social prescribing is a new thing to me. It's not a specialty that I know, so I didn't want to supervise. So we've worked in partnership with the voluntary sector, and the same for mental health and for physio. But that's quite an unusual approach in our area. And most people have recruited their own where they have. So I wondered what you thought about that, because I do worry in terms of we build these roles in to build our capacity, increase our capacity in general practice. But if people are trying to supervise them themselves, is that truly increasing the capacity if you don't work in partnership?
I think there's a number of models. I think that's a really good model. And I think for a lot of roles, particularly I've heard it for physio, for paramedic as well, and for the social prescribing link workers, actually subcontracting those workers from another organisation is a way of ensuring supervision. You can also, of course, recruit to your own organisation, but then make sure that you've got clinical supervision particularly available for those workers and that you hook them up to the other networks that exist, whether that's through the community trust or whoever else is there, so that they're getting managerial support from you. And that might be a way of making them feel part of the whole team, but also making sure that they're getting that that they're hooked into those networks. And I think working, maybe I've heard also people working across multiple PCNs, for example, so that the physios across multiple PCNs will come together to form a support group, the same with the pharmacists, that kind of thing. There's a different number of models, but I absolutely think that making sure that those roles have access to the same kind of supervision and support that you would expect to have within your practice for the medical staff is absolutely key.
A great point from Erin as well, around, the ARS scheme is a really positive move, but actually until there's funding to support some of the supervision needed, then actually there's going to be limitation on who can take which roles and who wants to take which roles, which may be slowing progress. Keep your questions coming in. We've just got a few more minutes, and then we'll bring things to a close. One of my interests, coming from having spent a bit of time in NHSE before sort of joining the general practice community, is that when policy wonks and sort of leaders within the system think about the value of primary care, quite often I think what they're thinking about is the benefits of sort of proactive care. And people often talk about the benefits of keeping people out of hospital, which is a terrible metric, I'm sure we all agree, but the benefits of keeping people out of hospital and keeping people well for longer. But in my experience of working in general practice so far, that's been pretty tough and it feels very reactive. I know there's some move towards this through the enhanced specification. I just wonder if you two, looking from your different vantage point, sort of see a change in this reactive proactive balance over the next few years, and if so, how you think that might happen. Becks, I don't know. This is a bit unfair because I've not warned you about it.
I understand the question. What are you getting at with reactive and proactive in terms of the system or individual practitioners?
No, in terms of individual practitioners and the care delivered. I think that there is clearly sort of organisational things that we can do to structure around being more proactive in the care we deliver, but quite a lot of the sort of acknowledged benefits of primary care in terms of, general practice saves the system money, and part of that is gatekeeping, clearly, but part of it is the idea that we keep people healthier for longer and we take strain off secondary care resource. But I haven't necessarily seen that much in practice, and the conversations I was having kind of in policy land when the long-term plan was being developed haven't met with my experience of delivering general practice to date. And there are loads of caveats around, you know, my practice and my placements, but I wondered if you saw a change in the sort of structure of care being delivered and how that might move.
So I think this probably neatly draws together a couple of different themes that we've been discussing. One is that I think that the proactivity, I'm wary of describing it as a luxury, but I think the reality that we all know is we have to deal with the problems in front of us first and prioritize and reprioritize. And we all do that on a kind of 10-minute basis in general practice, particularly at the moment. And unfortunately, and maybe I'm just speaking for myself and my practice, but I think our kind of desire to be more proactive gets gazumped constantly by the need to react to the next thing that we have to do. And so we can be more proactive to the extent that we solve the workforce and workload problems in general practice, and hence the circle continues to spin. So I think that's one part of it. I also think that there is perhaps a disconnect that you're alluding to, Will, between some of the kind of language that gets used in arm's length bodies around things like population health management. There will be others on the call who are much more expert in this than me, but I hear these things, these kind of phrases bandied around in meetings, and I don't see any of that really happening in reality in general practice on the ground. I think they're ethereal concepts, and I'm starting to see it trickle down to general practice a little bit through PCNs. But I think what that relies on actually is us having help and support to do that. I think I may be just speaking for myself, but that wasn't what I felt that I was trained to do as a GP. And general practice and primary care networks, I think, need analytic support to be able to do things like population health management properly, and to stop it just being parts of jargon that kind of wafts into our atmosphere every so often and we don't quite know what it is and it's not really tangible. If we want to do something about that, I think we have to widen the scope again of who we're working with. There is actually just a general problem. Like, we don't have much analytic capability in the NHS. So I wonder whether we hit the buffers there as well.
Yeah, I couldn't agree more with that issue around analytic support. I was working in Scotland recently, and they have outsourced a load of government analysts into primary care to help them do some of this work, and it's working really, really well. So they've got direct access to really expert analytical support. I also think that the relationship between public health and general practice got really fractured in the 2012 Act reforms, and I think we need to do something about rebuilding some of those relationships, because that analytic capacity and that understanding and all the data sets and all that kind of stuff sits in public health, but you guys don't have access to it, which makes no sense at all. So I think making sure that we can pay a bit of attention to how to rebuild some of that relationship between public health and general practice feels really important at that kind of more macro level. But yeah, absolutely, if you're going to be doing proactive work, you need the tools to help you do it, the headspace to help you do it. And I think it's also, as we get used to using these new roles coming in, freeing up the GPs to do the stuff that you do best and making sure that you're not spending your time. I've just seen the word firefighting leap out of my peripheral vision, but that's it. You shouldn't be doing all that firefighting. There should be a team around you thinking about it. Let's have enough workforce, whatever that workforce is. That means you've got the headspace to do that optimal care that you really, really want to do. But that will also take some back office support, and I'm an ex-NHS manager. Managerial support is massively important. Whether it's analytics, whether it's personnel management, whether it's any kind of management, you need that support and help to free you up to do the jobs you're willing to do.
I also think it's okay as individual GPs, and I think it's really important actually to ask ourselves what we enjoy about our job, and then how do we get more of that in our days. And if what I enjoy about my job is end of life care and trying to do that really well for my patients, then great. Like, do that really well. I am wary of us having to be the masters of everything and nothing at the same time. So I think it's important to remember, like, back to that kind of really core general practice, that is so important, and that has to be right at the center of everything we do. And it's so obvious to say, but it can seem very distracting when people are bandying around terms like population health management right and center, and making us all think we should be management consultants, and that's not what we are.
That's a really nice reminder. Thanks, Becks. And so many relevant comments through on the chat as well. Really useful. Nick, yes, there was some discussion at NHSE, certainly when I was there, about commissioning analytic roles in PCNs, and there are a range of pragmatic reasons they haven't done that, as far as I understand. But I'm out of date now, so I'm sure Becky and Becks will have.
I mean, maybe I think there aren't many analysts.
Yeah.
No.
And defining what they meant was hard, wasn't it, Becky?
Yeah, and also finding a place to put them and to give them the support they need as well, so that they're not out on their own. There's lots of stuff around that, but I think it doesn't take away from the fact that analytical support's really, really important.
Last sort of thought from you both, if I may, from somebody on the chat. What if you could give this group of early career GPs and GP registrars a tip as to how they could best influence the way the future of general practice looks? Where should we be putting our energy and our passion? Becks.
I mean, you're here. Like, thank you. I think I'm so grateful to everyone who is a part of Next Gen GP. I very genuinely believe that things like Next Gen, it's not the only thing, but it is an important thing in kind of securing the future of general practice, because your energy and enthusiasm and your desire to learn more and know more enables you to do more and give more. And so I think like this makes me feel very encouraged. In kind of direct practical terms, I think wherever you are, and lots of people will have said this to you before, whatever you are and whatever role you have influence, and you can do what you want to, do things, be interested in things, be curious, ask questions, offer to contribute. It doesn't matter whether you're senior partner in a practice or a trainee. In fact, at the moment, particularly at the moment, people are going to be very grateful for your offer of help and support. So get involved. And if you want to get involved at the local system, I think reach out to your PCN clinical director, ask what they're doing, see what your CCG are doing. CCGs may not be long for this world, so it may be that, and we didn't get into this yet.
Becks, that's tantalizing to drop in the last 5 minutes.
But the broader point is, you guys are on this call because you are curious. Take that curiosity wherever you want it to take you and engage with people. At least my experience has been that lots of people will engage with you, and the ones who didn't are probably not the ones who you wanted to engage with you anyway.
Thanks, Becks. Becky.
So the passion in this group is phenomenal, and I say that not just tonight, but the work that I see you do gives me energy and makes me do the work I do, because I think there's nothing more exciting than seeing like really passionate GPs who are ready to go ahead and change things. And you will change things, because you are going to be you absolutely will be those GP leaders of the future, those people who are being called by Department of Health and Number 10 to give their views, but you will be those leaders because you've got that curiosity and that passion. I would say yes, absolutely, keep asking, keep getting involved. I would also say, if you've got chance to look out of your day job around the system a bit, and kind of, if you can get the time and the headspace in any way to kind of lift up and have a look around to experience what else is going on in your system. And when you feel like it's really frustrating, finding like-minded people like this group to support you in what you want to do, so that you don't give up, and keep that network, keep that kind of that peer support around you just to sustain you, because you need to look after you. It's a truism, isn't it? But you just have to look after yourselves to keep yourselves with the energy to do this properly. And if you can do that as a group, there's nothing can stop you, I don't think. Not even politicians with an obsession with access.
Thank you both so much. It's been like the time's flown. It's been a brilliant conversation. I've loved every minute of it. And thank you to everyone who's joined us. We've kept a steady number of you, so that's great. That's a good sign. I've really valued the comments coming through, and the suggestions, the ideas, and the questions you've shared. Thank you so much. Becks, Becky, you have incredibly busy jobs and very influential and high-powered jobs, and we're really grateful for you to give up your time for free to talk to us tonight and share your enthusiasm for what you do, and also your challenge that we can be more influential than perhaps lots of us think. And on hard days, that's really nice to be reminded of. So thank you both. We've got so many great opportunities coming up with Next Gen at the moment. So we've got our Next Gen cast, which has got some brilliant new episodes courtesy of Nish Malik's beautiful interview style. Please do look on any podcast platform for those. We've got lots of new programs. We've got Cambridgeshire and Peterborough, the East Midlands, Bristol, Lancashire and Manchester coming together, and a Yorkshire programme, all open for applications now. So many of you will already have been part of programmes. If you want to join again in your local areas, or pass on the message to people you think would benefit from a bit of time to look up, think differently, and meet like-minded and enthusiastic people. We've got a feedback form for this session. It's gone out with an email I've sent to you all a few minutes ago, but Nish has also posted in the comment box the link to that. Please give us some feedback so we can continue to improve these webinars, but also give our thanks to Becks and Becky. It's always a really nice thing to be able to share your thoughts on the conversation with them. And our next national webinar will be the 2nd of March, so pop that in your diary, please. We've got Professor Martin Marshall, the chair of the RCGP, coming to talk to us. And I think there's probably not been such an interesting time to be chair of the college for some decades, and Martin's just an incredibly interesting guy with a really fascinating background in academia, quality improvement, national leadership roles. He's done a whole load, and I think he's got a lot of interesting stuff to share, a lot of interesting thoughts to share with us. Plus the opportunity for you to put your questions to him about whether the college is still relevant and what he sees the future looking like. So please do join us for that normal sign up link, and we really look forward to seeing you again then. Thank you again to Becky and Becks, and I hope you all stay really safe. I know it's really busy and difficult out there, but thank you for everything you're doing, for your patience, and for general practice.